find out that they have COVID. Let's see. Can give it a couple more minutes and then we can go.
I just want to introduce myself really quick. I'm Jonathan. I'm one of the incoming fellows at UC Davis. I work with Shakira, Dr. Vanderlyn. And she just kind of sent me the link to join this part right here. I just want to say hi to everyone. Just be kind of observing to kind of learn a little bit more about what you all do during these sessions.
Awesome. Nice to meet you, Jonathan. Where are you coming from?
I'm currently in New York right now. I'm finishing my residency there, and then I'm going to be going to Sacramento in a couple of months to do my global EM fellowship there.
Awesome.
Hi, Jonathan. You're Vietnamese or Chinese?
I'm half Chinese and half Filipino and Vietnamese.
Vietnamese drunk.
Yeah, so
so we begin.
Yeah, sounds great. Sounds good. So just to get you up to speed a little bit, do you go by Jonathan or John or?
Yeah, Jonathan's good.
Okay. Yeah, so Jonathan, usually the way that these sessions are structured is if you have absolutely no kind of background with it at all, basically each month is a different module set up much the same way that the U.S. Emergency medicine, like global and kind of overarching training structure is set up. So it ends up being about an 18-month curriculum to cover, the majority of the body systems, and we have a systems-based approach. So every month is a new system with some kind of being some doubling up. And then we kind of on a daily or rather on a weekly basis, we'll have some assignments of questions like kind of pre-study study questions that we send out that we'll cover for the first little bit of the lecture, and then we also send out some pre-reading to cover the material as well, and then we kind of finish off with the lecture for the rest of the session. So and then it depends on kind of who, most I would say probably about half and half is guest lectures versus kind of lectures provided by the fellows and the program directors. So that's kind of most of it for now. And I'm James. I'm one of the global health fellows at Utah. So
awesome. Great to meet you.
Yeah. Got it. So let me get here. All right. So we can share this, and everybody can see the sharing. Perfect. Okay. Similar so this is the neurology module, kind of finishing up the neurology module. In this module, I was hoping that we could cover last week we covered many of the stroke syndromes that can be seen with ischemic as well as hemorrhagic strokes. And this week, I was going to focus a little bit more on kind of an initial emergency department management of predominantly of ischemic stroke, but the kind of initial diagnostics are still the same for anybody largely that presents with kind of a focal neurologic complaint. So kind of with that in mind, for this first question, we've got a 63-year-old woman coming in with 1 hour of weakness. On your exam, you see that she has a near complete paralysis of the left side of her face, as well as severe aphasia, and she's unable to answer any other meaningful questions related to that. The remainder of her exam is normal. So using the NIH stroke scale, what would you anticipate her NIH stroke scale score to be? Awesome. Perfect. Okay. Love it. Good. Okay. So yeah, so in this case, the stroke scale would be calculated at 7. And that's kind of is broken down into a couple of different components. There are many categories of kind of components of the NIH stroke scale. There's anything from kind of general level of consciousness to aphasia, and as well as other language and other kind of focal neurologic deficits. So in this case, with the complete paralysis of a unilateral side of the face, that would be 3 points. Can look here and see. So complete paralysis of one or both sides of the face for facial palsy. You have severe aphasia, which would be mute, basically global aphasia, and can't answer any additional questions, or severe aphasia rather. And then because the patient is unable to answer any additional questions regarding their mental status, they would get 2 points in this category as well. So we can see basically that with aphasia, especially receptive aphasia, that that the stroke scale would generally be very high if they're unable to follow commands. And then being unable to answer any questions and having a severe dysarthria or severe aphasia also is indicative of a very high NIH stroke scale, which would be kind of representative of a more severe stroke than somebody with an isolated facial nerve palsy or an isolated limb or like extremity weakness. Does that make sense? Good. So yeah, we'll be kind of touching back on the stroke scale as well later on in the lecture. So for the next question, we've got a 68-year-old woman, has a history of hypertension, coming in with right arm weakness, facial droop on the right, and expressive aphasia that started approximately 5 hours ago. Her NIH stroke scale is 9. The initial non-contrasted head CT does not show any evidence of bleeding. Her blood pressure is 200 over 115. Using kind of the information provided, what would be the next step in managing this patient's blood pressure? Awesome. Great. Love it. Love it again. So the main component here is the kind of the timeline overall. So this is, there may be some practice variation from institution to institution, with some institutions having a slightly broader tPA or thrombolytic window. The predominance of institutions, I would say, in the US still kind of operate under a 4.5 hour, or in some cases a 3-hour window from onset of symptoms or last known well to be a tPA candidate or a thrombolytic candidate. So if she had come in 4 hours with 4 hours of symptoms, then this blood pressure would need to be treated to make her provide the necessary blood pressure to make her a candidate for tPA. But unfortunately, after 5 hours, the evidence is a little bit less robust to use tPA in this setting. And with that in mind, if she's not a tPA candidate, then there's this idea of permissive hypertension, which is an idea that providing additional general blood pressure, systolic and diastolic blood pressures being pretty severely elevated can also improve cerebral perfusion in the setting of acute stroke. And lowering blood pressure is actually associated with worse outcomes. So kind of the initial acute management is probably no need to do anything given that she's not a tPA candidate, but would largely or likely would need to have a slower reduction in the first, within the first 24 hours or so to kind of reduce the blood pressure by 15%, which is usually based on the mean arterial pressure. So the remainder of the answers are all looking at either lowering them specifically to make her a candidate for tPA, which she isn't, or the acute reduction in systolic pressure isn't indicated currently. Even in all patients, patients that meet inclusion criteria for tPA, there's about a 5 to 7% risk of spontaneous intracranial hemorrhage, and that is massively elevated in patients that have a history of a spontaneous bleed. So any benefit in these patients, statistically speaking, would be removed by the risk of harming someone by administering them tPA. So that's why those patients are not eligible. Kind of the remainder is whether or not this patient should go to a neuro or a stroke floor or a stroke unit. And there is certainly evidence within the US that specialized stroke care provided on a stroke unit provides better outcomes than a general medical floor. The patients there are seen, their cares are kind of more specialized, and they have better outcomes when the nursing staff, the ancillary staff, and the physicians that are working in those areas see more stroke patients. So good. Any questions about that?
Yeah, hello, John. All the patients, all the patients with the histories about the hemorrhage in the past, is not a candidate for the bronchodilator therapy. So, how many years did the patient can use the tPA? About assembled 10 years ago.
So I think that in that case, it would come down to a clinical decision or a clinical judgment. I think that you would find people that would say that 20 years ago, the patient had a spontaneous bleed and they've had no issues since, and the cause of their bleed was fixed. They had their aneurysm fixed or their AVM fixed. That in those scenarios, they may still benefit from tPA. But the general issue is that the risk of bleeding after tPA administration is already so high, even without any abnormalities, any increased risk, that when you administer tPA to those patients, even if their increased risk is relatively small, you completely remove the statistical benefit of giving them tPA. So they're, you know, if you see an improvement in one out, you know, or 2 out of 100 patients compared to no intervention with tPA, and then you all of a sudden have a double, you double or triple or quadruple their risk of bleeding, then you're more likely to cause a fatal intracranial hemorrhage than you are to lyse somebody's stroke. Does that answer your question?
Thank you, Chen.
Of course, of course. All righty, let me get out of this for just a second, and then we can go up here. Got it. Okay. Can we have this here? Can see it? Good. Okay. So today I'm going to kind of discuss a little bit more about kind of initial management and kind of identification and protocol or kind of protocolization of acute ischemic stroke, especially within the US, where this has become very protocolized. It's very kind of algorithm driven mainly because of reimbursement for money reasons, I would say. But there's also certainly evidence to support kind of an algorithm and protocol-based approach so that the patients that may benefit from tPA can receive it as quickly as possible. In the US, you know, in most emergency departments, we have, it's very similar to a trauma activation where someone comes in with a stroke activation when they present with stroke-like symptoms. So they come to the, you know, they come to the triage area. They say that I have left arm weakness. The triage physician or nursing staff kind of evaluates the patient preliminarily, decides if there's a reasonable likelihood that they may be having a stroke or similar, and then can continue kind of with the remainder of the algorithm to determine largely if they are a candidate to receive tPA, and if they're not, more recently there have been developments in thrombectomy for large vessel occlusions in the treatment of stroke. So basically, what I decided to do was to take I feel like a pretty representative protocol within the U.S. This is from one of the hospital systems that I work in. That's a very large hospital system that, you know, sees millions of visits every year throughout the entire hospital system. And they had developed kind of amongst their multiple hospitals what the kind of best cases in terms of stroke care and stroke treatment, especially in the initial evaluation and initial treatment period. So kind of looking back a little bit more, you know, ischemic stroke is certainly compared to other types of stroke. It's by far the most common in the 85 to 90% range. It's one of the leading causes of death within the US. The symptoms can be severely disabling even if caught relatively early and treated. Early treatment has improved outcomes compared to delayed treatment, largely speaking, and that there is a very kind of definitive treatment available. So the kind of similarly to what I was saying, we're working in the emergency department, and a patient comes in and they have some symptoms or signs of stroke. So they either come in with a frank stroke syndrome. So they have left facial droop, left arm numbness, and severe aphasia. Or they have left leg, numbness and weakness. Occasionally, patients will have severe kind of hemiplegia, or potentially some basilar artery stroke syndromes or posterior stroke syndromes will be kind of screened for and evaluated early. So oftentimes this is just from a triage approach, and the staff that is doing the initial triage may not be a physician. Oftentimes, in fact, it's a nurse in the US that have been trained in triage. So they have a very simplified kind of classification scheme or kind of evaluation for the possibility of stroke. So that's looking at sudden loss of balance or discoordination, patients that have sudden loss of vision, either monocular, sometimes binocular vision loss, or some other significant kind of focal vision loss or visual change, such as double vision. Facial weakness, arm or leg weakness, aphasia, dysarthria. And then the other component that they tried to obtain relatively early is the time of onset, which plays a huge role in the remainder of the algorithm and the remainder of treatment. So beyond the initial kind of screening testing, looking at kind of broad symptoms or broad neurologic symptoms, there's the NIH stroke scale, which we discussed earlier. We're looking at things from are they completely awake and alert, or are they obtunded, or somewhere in between? If they aren't obtunded, then are they able to appropriately answer questions and follow commands? Do they have visual deficits or cranial nerve palsies or like lateral gaze palsies? Facial weakness, arm and leg weakness, significant coordination deficits or sensation deficits. Like I had said, speech deficits and speech changes, as in slurring or severe dysarthria, and then neglect or kind of not being ambivalent to one side of the body. But we can see certainly that the testing and utilizing the NIH stroke scale is relatively involved, certainly compared to the initial kind of testing, which is basically, do they have any neurologic symptoms? So that this is one of the reasons why this is much more utilized for triage, because you can quickly identify patients that have clear neurologic symptoms and findings, compared to this, which is a comparatively speaking involved examination that may take, depending on your comfort level and the patient participation, can take several, even up to several minutes to complete. So now, after we've determined that they do have some symptoms, the question is, have their symptoms resolved? And if they have, then they are currently not experiencing a stroke that would necessitate tPA or likely other acute, within the next minutes to hours sort of intervention. And then, we need to determine when they were last well. So when were they known to be at their baseline prior to their presentation. And this is extremely important because of the remainder of the treatment algorithm. But some of the things that we can use to determine a much more accurate last known well time are the last time that they had a normal interaction with their family or friends or colleagues or work colleagues. If they were normal when they went to bed and have subsequently woken up with stroke symptoms, that would be a wake-up stroke, and their last known well would presumably be when they went to bed. Or depending on the degree of debilitation that the patient is experiencing, either due to severe aphasia, severe dysarthria, or being obtunded, the patient may be able to tell you exactly when the symptoms started because they looked at a clock or they looked at a watch or their phone when the symptoms began. Like all of a sudden they noted that they were starting to slur their speech and they looked down and looked at their watch, which is considered an accurate and reliable measure for last known well, as long as the patient is describing it in a reasonable fashion. So, I would say most of the importance for determining the last known well falls into the 0 to 6 hour category, or depending on your institution, 0 to 3 or 0 to 4.5 hour timeline. So that's the timing here is extremely important because it's going to determine the subsequent steps in management. So for like an acute stroke happening within the institution or your clinical judgment time frame that may be acceptable to administer tPA. So we have kind of some evidence of an acute ischemic stroke. They have focal neurologic deficits or other neurologic findings that would put that in your mind or make you consider stroke as a highly likely underlying etiology, and especially if they have debilitating symptoms. So in these cases, we'd be getting a CT as well as a CT angiogram to look for evidence of ischemic stroke and thromboembolic disease, or depending on if CTA is not available, simply a non-contrasted head CT. And then after we have gotten that, we've identified on CT angiography an M2 or whatever ischemic lesion causing this, that would be consistent with the patient's symptoms. We have to very rapidly evaluate the patient to determine if they have, if they're a candidate to receive tPA. And this is where, most of the initial evaluation in terms of importance, I would say, develops from the emergency department. So do they have an active contraindication or a potentially treatable contraindication to tPA? Because that is the next steps, and the risks of administering tPA are extremely high, and trying to remove or eliminate the highest number of people that aren't candidates while still being able to rapidly administer it to patients that are can make a large difference in terms of overall outcomes. So these are many of the kind of exclusion and inclusion criteria that we have previously discussed. And depending on the institution, depending on the work that you have developed with the kind of neurology colleagues, with the remainder of the hospital staff. These may change slightly, but I would say that the initial absolute contraindications in patients that have had symptoms for less than 3 hours are basically the same everywhere. So giving tPA to someone that's already received tPA in an outside hospital is probably not a good idea. You don't want to double dose tPA. That is extremely, extremely detrimental. If they have CT findings that would be indicative of a contraindication, so that would be, do they have an intraparenchymal or subarachnoid hemorrhage? Do they have other evidence of multifocal infarction or an extremely large area of infarction that would be highly likely to develop bleeding? Systolic blood pressure greater than 185 or a diastolic greater than 110 that cannot be lowered despite maximal treatment within a timely fashion. So if somebody comes in and they've had a stroke, they have a stroke on imaging and their blood pressure is 195 over 120, and you have them on 3 antihypertensive drips, then they are still not a tPA candidate, despite having their known kind of potentially a minimal disease. So the risk with blood pressure is greater than 185 over 110 is largely due to the massively increased risk of spontaneous hemorrhage, which is the same with all of these. As all of these contraindications. Same thing with platelets, PT, or INR, or if the patient has a known bleeding disorder. So you can't give tPA to patients that have acquired or congenital bleeding coagulopathies. An INR of greater than 1.7, or if the patient has kind of obtained or has been using oral anticoagulants. Those are all, I would say, hard contraindications to tPA administration. Others would be, a little bit more left to clinical judgment. Severely low or elevated blood sugar, whether they've had a seizure that may indicate that the patient is still postictal or has a Todd's paralysis. If they've had a recent surgery that is within the last 2 weeks, or some other major trauma. If they've had another stroke within the last 3 months, if they've had some other intracranial spine surgeries, or depending on the degree of their symptoms, if their symptoms are not disabling, the risk of administering tPA may not be valuable in those cases, because the risks of administering tPA may be death for somebody if their only stroke symptom is isolated hand numbness or isolated slurred speech. But that is on a kind of a case-by-case basis. And then, we can see kind of the remainder of the exclusion criteria, that, oftentimes it's any history of AVMs, intracranial hemorrhages, brain tumors, patients that are pregnant, although, like I said, that's not an absolute contraindication. And then kind of depending on the rest of the your timeline, whether if the patient is at the extremes of age, so very elderly, if they have an extremely large stroke, or if they have severely debilitating symptoms, they're not likely to improve significantly after tPA administration, and would put them at a significantly elevated risk of both bleeding and kind of ongoing morbidity, and a poor outcome that may not be useful as well. And then here's an additional kind of evaluation for the inclusion and exclusion criteria that, you know, kind of reiterates most of the same things. So full hard exclusion criteria, and this is simply a different institution. Full exclusion criteria, and then patients that have a relative exclusion. So, you know, full exclusion in this place would be prior strokes, prior hemorrhage, known intracranial malignancy, and then, you know, other components as well. So once we have kind of reached this area, so we've gotten, patient has arrived, they're within an acceptable window. We have a CT that shows that they have, there is evidence of a stroke that is consistent with their symptoms, and they are a candidate to receive tPA. We, you know, have to make the decision to administer tPA or not. And some of that is going to depend on the patient making, you know, having some input into this decision. And sometimes this is an often used graphic to describe to patients what their outcome will be or may be following tPA. And this is kind of putting it into terms of kind of all, you know, good, as in like they may improve slightly, or their risk of improvement is here compared to doing nothing, as well as the risk of developing a significant bleed, intracranial hemorrhage that may result in death. So when put into these terms, you know, doing nothing versus a tPA administration, the decision is not as clear cut as some of the other decisions that we make in terms of risky or relatively risky interventions. And there's certainly a lot more kind of data that's emerging that is a little bit on the side of questioning the utility of tPA administration at all under any circumstances. But I think that that's something that will kind of continue to be argued about for many, many years. So additional complications of tPA after it has been administered. One of the more common ones is actually development of angioedema. It occurs in about 5% of patients. And the presentation is almost universally unilateral tongue swelling and anterior oropharyngeal swelling. It occurs, again, almost universally either during or very shortly after tPA infusion. So within the first, 1 to 3 hours of administration of tPA, we can expect, if they are going to develop angioedema, it will be within that timeline. More rarely, about 5% of the time, it may result in posterior oropharyngeal or bilateral oropharyngeal angioedema that may be airway threatening and would necessitate intubation. And then the treatment beyond intubation, if it's indicated, would be treatment for kind of anaphylaxis, but there's actually no evidence to support this practice at all. There isn't any evidence to support any particular intervention with tPA-induced angioedema. So TXA or aminocaproic acid or other kind of anti-tPA agents don't have any effect either. So it's kind of confusing to determine what to do in these scenarios. So the additional kind of major complication associated with tPA is very unsurprisingly bleeding. It occurs similarly in about 5% of patients. As far as I could tell, there's not any necessarily any overlap between patients that develop angioedema versus intracranial spontaneous hemorrhage. But this complication is certainly much more pressing and severe than the angioedema, because about 50% of the time it's fatal. And then another large proportion of the time it has severe residual complications. And treatment is with cryoprecipitate. Usually the recommendation is to start with about 10 units. And then additionally, treatment with TXA and possibly with FFP and prothrombin complex concentrate as well. But the mainstay of treatment is with cryoprecipitate. And then, if you do have a consideration for development of intracranial hemorrhage, repeating imaging and getting the neurosurgeons on board for potential intervention is extremely important. So kind of moving back a little bit to the kind of initial evaluation. So the patient has come in and instead of being 2 hours after their symptom onset, it's actually 12 hours or it's a wake-up stroke. And in these cases, the initial evaluation is very similar, but there's a little bit more kind of evaluation and kind of consideration for a large vessel occlusion and other intervention that may be amenable to thrombectomy with the interventional radiologists or the interventional neurosurgeons as well. And it depends on what the capacity is at your institution as to whether this is even available. But in these cases, in a kind of a delayed presentation of stroke, this is largely the only additional care pathway that is going to result in some additional intervention acutely. The rest of it is supportive care, evaluation for, and additional medical management of stroke risk factors. So in these cases, kind of evaluating for, patients that would be amenable to endovascular or interventional radiology thrombectomy are patients that have a large vessel occlusion that's in like an ICA, an MCA, like a large branch of the MCA stroke that would be easily retrievable. If they have very significant stroke symptoms that would likely respond well to the thrombectomy. And then some CT perfusion criteria that I feel like is a little bit beyond overall the kind of scope of our lecture, but there's certain criteria that are utilized to determine if the patient will likely see benefit from reperfusion therapy. So that's mostly what I have for now. Do we have any questions or additional thoughts?
I think it's same in Vietnam. Same.
I'm sorry, Dai?
I think this protocol is same in Vietnam. In Charai, we have the same thing here. If you have a stroke within 6 hours, we do it very quickly, the CTA and everything. And we have a neurology doctor come in and have us to do the RTBA. And we have a neurosurgeon, and we have the doctor, amazing doctor who care about CTA and review for 3D actually up to plan.
Yeah, for sure. And it's very interesting, and I think a lot of it goes to show just how effective the utilization of stroke treatment algorithms has been to show that it's very widely utilized, because the earlier the treatment can be provided, the better the outcome, as a general rule. And the kind of initial evaluation is virtually the same in all of these patients anyway. So having the protocol involved to remove the decision burden from your mind, from the mind of the treating physician and the treating emergency physician, is very beneficial from that perspective. Sometimes it can feel very frustrating in the US, because we have patients that are worked up and evaluated as strokes from the triage area that would never be candidates for tPA for a variety of reasons. And the kind of resource utilization that is wasted in many of these cases can be very frustrating. Or patients that, present and very obviously did not have a stroke, but were activated as a stroke from triage by the nursing staff, can certainly be very, very frustrating. But so in Vietnam, do you involve the patient in the decision to administer tPA, or if they have a stroke that you think would benefit, do you just do the tPA?
In Chile, we prefer to do the endovascular therapy because it's very quickly and it's very easy to do it. If we ever fail for endoscopy therapy, we think about the. So first thing we think as the endovascular therapy first. And if they cannot do it, and we will review for RCBA. That's that thing happening in Chile right now.
In UMC's videos like hospitals shows different things that the patient come to above 6 hours. So we do immediately like the patient come the first hours, and we train the patient to check the MRI with the perfusions and call the doctor in the truck teams to decide to and to do the activities for the patient. So with the patient comes to about 6 hours MRI perfusion in UMC.
Got it. Yeah.
And then with the patient is come to below 6 hours to do the tPA, and then they use the tPA, and after that come the doctor neurology decide to do the activities or not.
Got it. Yeah, for sure. That's that's certainly, that's definitely amazing that all of the hospitals there have access to such very specialized, highly technical care, and that's great. There's definitely many hospitals in the U.S. that interventional radiology and thrombectomy are not available. Even relatively large hospitals. We try through the pre-hospital EMS setting to divert those patients away from hospitals that don't have those capabilities, but you can't ever stop someone from walking in the front door or being wheeled in the front door if they've had a huge stroke. So it's challenging sometimes working in a smaller hospital to make the decision if somebody will be receiving tPA or not, if they aren't able to be transferred. And like I had said, there's certainly a lot of kind of controversy about whether we should be giving people tPA, period. And I think, here within the next 10 years, hopefully we'll have a better answer to that question, and it will be a little bit more, easy, a little bit easier of a decision to either, do or don't give it. But awesome. Well, thanks everybody for your attention. Any other questions or concerns for right now?
No. In Ho Chi Minh City, not all the hospitals have a stock team like JRA and UMC. Small one don't have it. Like, so if they have something problem like the stock, they transfer directly to the stock center. Just like we have a 4 or 5 hospital who care about the stock. So we have called that the stock unit. So if you have a problem, they will transfer to some center, the stock center, and the stock team to do a tPA or vascular therapy, something like that. That's in Vietnam right now, in Ho Chi Minh City. Not all about, right? Just like USA.
Yeah.
And we had the surgery, surgeries and surgery neurology roles. In the patient had the ischemia in the left, edema, so the surgery decide to open the cranium or not.
Yeah.
So thank you, Jam. You have a good one presentation. Thank you.
Awesome.
Yeah.
Thanks everybody.
Yeah.
I'll be talking to you soon. Okay, everybody have a good day.
Yeah.
Jonathan, it was nice to meet you. Look forward to seeing you soon. And certainly if you have any questions or concerns, or whatever, thoughts or whatever, certainly don't hesitate to shoot me an email. You can get it from Molly or Shakira or anybody else. So
awesome.
Yeah.
Thank you for letting me. It was great meeting everyone. Thank you very much.
Yeah. Thanks, Jam.
okay. All right.
Jam, send us different point. Thanks.